a free 4-part webinar series sponsored by the Home Health Quality Improvement National Campaign and the Institute for Healthcare Improvement. We're so pleased that all of you have joined us today for our first live session on February 19th, 2013, and we want to jump into today's presenters as quickly as possible. So in looking at what we will be talking about today, our objectives include identifying the current state of home health quality and why systematic improvement is necessary. We'll also describe the setup process for successful improvement work, including leadership actions. We'll describe 3 questions for the model for improvement and describe how this tracks to lean. We'll also list key characteristics of a project aim statement. If you have questions at any time throughout today's live presentation, please email them to hhqi@wvmi.org, and we'll get to as many questions as we can during the live webinar broadcast. Additionally, please note that handouts from today's session will be posted to www.homehealthquality.org tomorrow, along with a recording of today's live webinar event. In looking at the agenda for today, what we'll be talking about, first of all, is the current quality environment for home health care and the need for systematic quality improvement. For those of you unfamiliar with the Institute for Healthcare Improvement, or IHI, we'll let you know who IHI is and what they have to offer. We'll also cover what we need to know about systematically delivering better care, basically the science of improvement. We'll also have a key focus on what leaders need to do to advance quality improvement in the home health setting. And we'll cover homework that you can do before our next session in 4 weeks to become apprised of this information and these activities that we are presenting today. So now I'm pleased to turn today's presentation over to Cynthia Pammon, who is the lead for Million Hearts and Disparities programs and the government task leader for the Home Health Quality Improvement National Campaign and Advancing Excellence National Campaign. She is with the Centers for Clinical Standards and Quality Improvement Group at the Centers for Medicare and Medicaid Services, or CMS. Cynthia?
Hello, everyone, and I'm so grateful to be able to present to you today. I just wanted to briefly go over, and many of you already know this, but just in case, I just wanted to lay the foundation for why systematic improvement is very crucial to the work that we do. Just to remind you, the OACC, as you know, is required as a part of the conditions of participation that CMS requires for Medicare certified home health agencies. And with the HHCAHPS, or the Home Health Consumer Assessment of Health Plans and Services, that is what the information we like to see that the patients tell us about their experience with the home health agencies. And then next is the Home Health Compare. That gives us publicly reported data that you all give to us, voluntary, public reported subset of measures that we look at and we say, what's going on with individual home health agencies? It allows the public and patients and the caregivers to select the agencies that would meet their needs. The CMS Home Health Quality Initiatives also include, as you know, the Home Health Quality Improvement National Campaign. And we're currently focusing on the acute care hospitalization measure, the oral medication management measure, immunizations. We're focusing now on dual eligibles and the underserved populations that we would like to call our UP program. And you should have received information on that in terms of a best practice intervention package. However, there is still a whole lot of work to be done. What may be missing is we need to take all of that data, all of the Home Health Compare, all of the work that we're doing in the Home Health Quality Improvement National Campaign, all of that HHCAHPS data, and we need to do something with it. And what we need to do is we need to link the data from the quality reporting to the science-based improvement activities within the agencies. It's not often that I come across people who don't know what to do. There's so many competing priorities out in the agencies, the staffing, the regulatory requirements, and some of it that we put on you from CMS. There are a number of things that prohibit you from doing what it is that we like to call systematic improvement. The other thing that is missing is the ability to sustain improvement and or make the necessary changes in the event improvement does not occur as planned. We have to be able to empower our agencies to do what needs to be done in order to demonstrate the improvement. And then also, we need to embed improvement into day-to-day operations within the agencies. And that includes to support staff, teams, and making improvement a priority. Again, with so many competing priorities, it's very difficult. We need to support internal and external communication and collaboration within all of our agencies. So that said, we also know that, you know, a lot of you are doing great jobs, and we know that there is, on an individual agency level, from what I can tell and what I'm able to see at CMS, I don't get a lot of individual data, but I get the national data and the aggregate information that we need to see how things are going. And for example, with the acute care hospitalization measure, there is a 1 in 3 or 1 in 4 chance that the patients that are seen in the agencies are go back into the hospital for whatever reason. So this systematic improvement will help us design processes and procedures that we would be able to demonstrate at an agency level how to make a change in something like the acute care hospitalization. So that said, I'll turn it over to our partners with IHI, and we will continue on with our webinar.
Thank you so much, Cynthia. We really appreciate that. I'm now pleased to introduce, first of all, our keynote presenter for today, who is Corey Seven with the Institute for Healthcare Improvement. Corey is a director with the organization where she has led work in redesigning the clinical office practice, improving transitions into home health care, emergency department flow, improving transitions in care to reduce readmissions and spread. Corey is a nurse practitioner with a clinical specialty in adolescent, preventive, and community health. Her past experience includes 26 years of working in a variety of community settings, including public health, schools, and community health centers. Before coming to IHI, she served as Vice President of Operations at a community health center in Lafayette, Colorado. Corey received her BSN in 1976 from the University of Michigan and her MSN from 1980 from the University of Cincinnati. Joining Corey today will be Kate Bones, who is a project director also with the Institute for Healthcare Improvement, where she has managed multiple collaborative quality improvement programs, research and development initiatives, and strategic partnerships for 12 years. Kate manages IHI's Scientific Advisory Group and serves as a collaborative director in IHI's State Action on Avoidable Rehospitalization STAR initiative. Kate has a background in community health and policy. Now, please join me in welcoming Corey Seven from the Institute for Healthcare Improvement. Corey?
Thank you, Shannon, and thank you, Cynthia. That was a great lead-in to the webinar today, so really glad that you could join us. And hello to all of you out there. I'm really pleased to be here and starting this call series on improvement. So we thought it would be good to start out with an introduction to IHI so that you know a little bit about IHI, who we are, and what we're about. IHI exists because there's an enormous gap between the healthcare that we have and the healthcare that we should have. It's really a quality gap that's so large that the Institute of Medicine refers to it as a chasm. The flaws, you all out there working on the ground every day know this already. The flaws in the current system are really indisputable, that the best known science, it's not reliably applied. It's really hard to do the right thing every day. There's widespread inefficiencies that waste precious resources. And our system, which really aims to heal, often does just the opposite, leading to patient harm and unnecessary deaths. So that's really why IHI exists. Our mission at so the visual on the screen is tells you a lot of information about IHI, but in a summary, our mission is to improve health and healthcare worldwide, and our vision is a world where everyone has the best care and the best health possible. We know that we can't do that alone. We're actually a small organization of about 130 people, and so partnerships are really important to us. We are a global organization. We recognize that we're interdependent with all the people who work in healthcare and the systems out there trying to deliver the best care. We know that the best ideas may come from the least privileged parts of the world or people who aren't in positions of power. And so we really are looking for ideas in every corner of the world. We're deeply committed to the belief that everyone has something to teach and everyone has the opportunity to learn. All right. We have a lot of free resources, and this slide is up here. You can refer back to it if you want to go back and sign up for some of these things. We do have a free newsletter this week at IHI that you can sign up for. We have an audio radio program called WIHI. You can go onto our website and look for upcoming programs. I'm hoping that in the 2013 we might have one on home health care. And there are just tons of resources, tools, stories, lots of information on IHI.org that are free, and so we encourage you to go onto our website and take a look. We thought that we would put up just a sampling of some upcoming IHI programs that might be of interest to a home health care audience. And so you can see these here on the screen. We have lots more programming. The IHI Global Trigger Tool is a safety tool for measuring adverse events. There's a Reducing Avoidable Readmission seminar in Chicago in March. Another seminar focused on frail elders, building a care system in Denver, Colorado in March. And then we have two big conferences a year. One is our IHI National Forum, which is in December. But the other one is focused specifically on issues around office practice and work in the community where home health care resides. And that international summit is in Scottsdale, Arizona, April 2013. So that's a sampling of the kind of programs that we have at IHI that might be of interest to this audience. More specifically, the work of IHI connects to home health care in two specific areas of work. One is the STAR initiative, or the State Action on Avoidable Readmissions. You heard that Kate, who's here with me today, is one of the directors for that work. I also work in that area. And the STAR work is IHI's work partnering with the Commonwealth Fund to look at what has to happen in order to improve transitions in care, mostly from hospital settings to care settings in the community, which is where home health care resides. You can't really read the text in the little boxes underneath the blue curves, but that's really where home health care resides, or transitions to a higher level of care for people who have multiple complex conditions. We know that improving transitions in care needs the foundations of a couple things: patient and family engagement, cross-continuum team collaboration. One thing that's really clear, that if a national goal is to reduce avoidable readmissions, it can't be done through any one setting, but it has to happen because transitions in care and care for patients is designed across all healthcare settings, and home health care is really an important player in that area of the work. And then we know that part of the foundational work is health information exchange and shared care plans, so that each person's care is customized, is seamless, and designed to help them stay safe and at home. All right, the other area of work that IHI is involved in that home health care is a really important player in is IHI's Triple Aim. The IHI Triple Aim is where there's a goal in any healthcare system that positively impacts the health of the population, the per capita costs, and the patient experience of care. And And again, this is working across care settings, and this is also where home health care touches IHI's work. So that was a really fast summary. I can tell I'm speaking really fast, but we have a lot to fit into this call today. So happy to take any questions when we get to the Q&A. I encourage you to go to our website and just learn a little bit more. We're hoping that all of you on the phone will become partners with IHI in our goal of improving healthcare systems really across the world. So now let's dive a little bit into the system for improvement and improvement science. And just as a heads up, this call will be more didactic than the subsequent calls coming up because we want to lay a foundation in this call. So we will have a couple times for questions and answers, but just so you know, it's going to be a little bit more didactic than the other calls coming up. So what we see here on the screen, every system is perfectly designed to achieve the results that it gets. I know that in my own work as a nurse and a nurse practitioner through the years, it often felt that as I was trying to do the right thing for the patient and do the best thing, that perhaps when things didn't happen right, when there were mistakes and maybe even harm, that maybe it was my fault, that I didn't know enough or wasn't diligent enough or resourceful enough. And what we know is that in looking at systems, and healthcare is definitely a system, that although individual heroic efforts, individual knowledge and skill is obviously really, really important, that the systems that we work in, the way that the processes are set up and interconnected really drives the results that it gets. So when you look at your acute care hospitalization rates, or if you're looking at readmission rates, or any of the data that you look at, what you can know is that the system or the way that you are set up to deliver the care you're delivering, the way that that's set up is really driving that result. And so what that means is that in order to get a different result, so better financial outcomes, better patient outcomes, lower acute care hospitalizations or readmissions, any outcome that you're looking for, if you want a different result, you need to change the system, and that's what improvement science is all about. At IHI, we use the model for improvement developed by associates in process improvement, written up in this book that you see here on the screen, the Improvement Guide. It's a great book if you decide to get into improvement or you're already in it. It's a great reference book to have. But it's summarized in this model for improvement. It's a simple model, but a powerful model that can really help you drive your improvement and drive the system changes needed to get different outcomes. This evidence-based model is rooted in the work of W. Edwards Deming, and we're going to dive into it in more depth here. So the model for improvement, again, it's a simple but powerful model to help guide your improvement. There are 3 questions that orient us to our improvement. First, we look at what are we trying to accomplish. So really setting out, and we're going to spend more time in just a little bit on writing an aim statement and defining what is it that you're trying to accomplish. The second question is, how will we know that a change is an improvement? So you could spend a lot of time changing a lot of things. How will you know which ones matter? How will you know if you're actually impacting the result that you wanted to get? And that is focused on measures and the use of data, which we know home health care is rich with data, and a lot of what will be really helpful in the area of home health care is learning to use that data for improvement. And then the last question is, well, of all the things that we can do, what changes can we make that will really result in improvement? And that's where the resources of the Home Health Care Quality Improvement National Campaigns is really amazing, because what they're giving to you basically are the evidence-based changes that are going to make a difference. So you don't have to go do literature searches or, sit around and think about, well, what should we change? They really are being given to you, so that's really awesome. And then this bottom part of the model is what we call PDSAs, or a plan, do, study, and act cycle. And basically, once you have your improvement set up with the 3 questions for the model for improvement, you use iterative learning, or PDSA cycles, to learn what to change in your system and how to change it in your system. So that's basically the model for improvement. This model and using it on the ground is very compatible with Lean. In Lean methods, you also define what you're trying to accomplish, you set up your measures, and then you do iterative learning, quick iterative learning, using Lean methods to learn how to change your system. So it tracks very nicely with Lean methods. All right, so I've already gone through these 3 fundamental questions, but just to say it here, that as you get into your improvement work, using these as a mantra and a North Star to help guide you in your work can be very helpful. As Cynthia said in the beginning, there are so many competing priorities, and in healthcare we're running so fast, and I know that in home healthcare you're running very fast, that as you get into improvement, it's very easy to get sidetracked. So really using these questions in a very robust way to orient you can be very, very helpful. There's also a sequence for improvement, and we're not going to get into it a lot on this call, but it's important, and I wanted to put it out here, that there's a sequence, that you've written your aim, what you want to accomplish. We're going to look at some a little bit later, but say we want to reduce our acute care hospitalization rate by 20%. So you've set that, you've set up your measure, you've looked at the changes that the national campaign is giving to you, and then there's a sequence to improvement. You develop a theory, which is what your aim is, and a prediction that if we want to reduce acute care hospitalizations, your theory is we need to work on improving medication management, engaging patients, and then partnering across the care continuum so that we get the information that we need in a timely way, just as an example. So you have a theory, and you say, well, if we work on all those, we think we can reduce our acute care hospitalizations. And so you're going to start testing changes in all of those areas. And you test under a variety of conditions. We'll talk more about that in the next call. Once you understand what you want to change in your system, how you deliver care, and how to do that, then you'll start to implement it. You'll say, this is how we want to do our business. This is how we now need to train and recruit and support our staff. These are the processes that we're going to use to communicate, et cetera. Then you start to implement and make it the way you do business. And then at some point, if you're a large enough agency, you spread it to all your staff at all of your locations. So the point of this slide is just to say there really is a sequence to improvement. A lot of people make the mistake of saying, well, we're going to, this worked over at this agency, we're going to implement it. And part of doing really successful improvement is really doing this testing really well so that you know what you need to change and how to sustain it. So that's really the main point of this slide here. All right. Hopefully we're getting lots of questions sent in as we go through this. So now I want to, with that background, take a step back and say, well, what does this look like in real life? So let me just walk through this a little bit. So we already talked about the model for improvement. We talked about testing changes using the PDSA cycle, which we'll get into the next call. What does this look like? Well, you set your aim. You set up a dashboard of measures. You'll have some outcome measures like reducing acute care hospitalization, but you'll also have some process measures like perhaps costs, because you can change a lot of things if cost is not something you need to worry about, but that's not the world that we live in. You might set up process measures around medication reconciliation, patient engagement, those kinds of things. So you'll have a dashboard of measures, and then you'll have change concepts, and change concepts are the big buckets of changes like medication management, like people with complex conditions and engaging patients and families. So they're big buckets. And then from those big buckets, you and your staff develop change ideas, and these are the ideas of things that you want to test on the ground. So just to give an example, if I'm one of your nurses and I'm doing home health care visits to people recently discharged from the hospital, you might have done an assessment and said, well, you know, our communication with the discharging physician doesn't work very well. We don't get information. And so you might partner with that hospital and set up a test where on the next patient that I go do a home visit on that's been recently discharged, we're going to set up a real-time method to call each other so that any issues based on the discharge plan, information I don't have, clinical issues for the patient, we're going to test just on one patient whether we can do a real-time communication. So that's an example of a change idea that you might test. And the visual here is the idea that you do many, many small iterative tests of change to see what works, and you build your learning over time in the big buckets of change concepts. Hopefully that was clear. Please send in your questions, and in the next 3 calls we'll really be focusing on that part of it for the most part. The change concepts and change ideas, as I said, the Home Health Care National Campaign is basically handing you amazing, I would say amazing, evidence-based changes and ideas and resources that you can test. All right. We wanted to spend some time on this call because the next calls really are going to focus on testing changes and how you build that learning. We know that leadership is an incredibly important part of successful improvement and successful system changes. So we want to spend some time on this call talking about the role of leadership and specifically the kinds of things that it's important for leaders to do. There's many things leaders need to do, but for successful improvement, there are some specific things that aren't necessarily widely known. So we wanted to spend a little bit of time on this call talking about that. We know also that that individuals can seek improvement. So if I was a nurse in one of your agencies, I could say, I want to improve my patient engagement skills, and I could study and I could do tests of change on my own, and I would learn a lot, and it's a really valuable thing. However, in order to make really those system changes that are going to impact things like acute care hospitalization rates, your financial outcomes, patient experience of care, you really need to make those system changes, and that's really the leader's job to lead that piece of things. So let's look at what leaders really need to do. So it's important for leaders to make sure that the focus of the improvement matters, that it's something that's strategic priority for the organization. In healthcare, there's too many things going on, too many competing priorities to spend time, energy, and resources of anyone doing something that's just not important. It's important for the home health care leader, could be a CEO or director, maybe you call them something different in your agency, to organize an internal improvement team and officially sponsor the work the team to engage in the work. So it's important to put together ideally a cross-disciplinary team and say, your work is to use improvement science to improve X, Y, and Z. Let's just say acute care hospitalization rates. So putting together a team and then officially telling people that that's what they're supposed to do. And then third is just ongoing support for the work of the team. They need time to meet. They need support to test changes. So if you're going to change something different, maybe it's a little outside of how you normally do things. It might be against policy. There's ways to set up tests of change that are low risk. So they need support to do that. And it's important for leaders to remove barriers. And in this whole world, especially around reducing acute care hospitalizations, reducing readmissions, a lot of the barriers relate to partnerships with hospitals and primary care providers and all community services. So really helping to create really good partnerships so that they're not a barrier. It's important for leaders to give ongoing attention and communication with others and support for that cross-setting collaboration. So important roles for a leader. And here's just some recommended infrastructure and strategy to achieve results. We think it's important to designate an executive leader to do the things that I just talked about. You know, and depending on the size of your organization, you might have CEOs and COOs and CNOs and CMOs. Those would be considered executive leaders. In the really small agencies, people probably wear many hats, but you want to identify someone who is in a decision-making role and can lead the work of improvement. So again, to set priorities, link quality improvement goals to strategic plan, etc. Then to reinforce that the next step would be to convene an improvement team to really test those changes and to see what of all the things that you might change are the most important things to change to get different kinds of results. It's important to have a day-to-day leader or someone appointed with the time or some time to really drive that improvement work day-to-day that can convene meetings, coordinate the iterative learning, perhaps collect data, but someone who's really doing that project management and driving the project forward. And then third, it's important for the leaders to identify what are the opportunities for improvement, establish a work plan for testing changes, and then leading the implementation and spread of the successful improvements. So let's talk a little bit about how to identify opportunities for improvement. One, you want to look at your current state. And so looking at your baseline data, Cynthia outlined all the different kinds of data that's available to you. I know that you're very familiar with that. What is that data telling you, especially on the key things that you might want to improve? You might do chart reviews to identify system failures. When we talk about system failures, we're not talking about staff issues, but we're talking about what are the kinds of things that just systematically don't seem to be going well in our system. The ones that I've heard about for home health care, and I'm sure you'll have a list of others, are things like we don't get the discharge plan in time for that first home visit. We don't know what the medications are. The medications often don't match. We don't know the last labs. You know, we don't have information. It's hard to engage patients that have many, many different medications and complex conditions. It's hard to engage them in their care in ways that then they can participate effectively in keeping themselves safe and at home. So those kinds of things, what are those system failures? And again, you're looking at that not for judgment of staff or even your agency, but those are the opportunities for improvement. At IHI, we think that it's important to not just look at the data and not just look at the charts. That's clearly an important source of data, but also to do patient and family interviews. Maybe take a look at and reach out to patients that were recently discharged from the hospital, and it's a little bit down the road. What was that like for them? What would have made it better for them? That kind of thing. And then just do staff and clinician interviews. You can also do observation. Just watch each other go about your work. Can give you a lot of information. On this next slide, we have at IHI, we actually have a series of how-to guides on improving transitions in care. One is a hospital-based improving transitions in care from the hospital. We have one for home health care, improving transitions in care for home health care, and this comes out of that home health care guide. We also have one, by the way, for office practices and skilled nursing facilities. So if you go onto our website and search for STAR, you'll be taken to those how-to guides. This is pulled out of the home health how-to guide, and it's just our recommendation on how to get started in understanding your current state. So picking the last 5 rehospitalizations or hospitalizations to identify opportunities for improvement, doing chart reviews, And then for those patients, conducting interviews with the patients and their family members, and then also the clinicians. And then reviewing your patient experience data regarding communications and discharge preparations, and reviewing your OASIS data. So if you're not sure what to do in understanding your current state, you could take this slide and just try it. With 5, we think that 5 patients is enough information to give you a systems point of view that you know, that it will get you going in a very robust definition. All right, so I think here we are going to stop for questions. I've kind of completed what we wanted to put out for leaders, and we're going to stop for questions, and then we're going to talk about aim statements. So Shannon, do we have any questions in the queue?
Yes, we do, Corey. And I'd like to remind everyone, if you have questions, please email them to hhqi@wvmi.org. We have several queued up now for our first question break, and then we'll take a break a little bit later in the webinar as well. The first question is for you, Corey. It asks, can you give me some pointers or guidance on where to start? I'm struggling on what to improve first.
Great question. So there's 2 ways to go about this, I would say. And you've heard me go through the first way, is do a current state assessment. What seem to be our most common system failures, the things that don't work well? My understanding is limited, so you'll have to see if this fits in your environment, is that partnerships, especially with hospitals, often are quite problematic, that getting the information that you need to do the kind of clinical job you need is often difficult. You know, getting information, as I said, in a timely way, being able to communicate with people after the patient's discharged and you're in their home and you need to reach out to the providers of care, those kinds of things are problematic. Those are the things that we think are really important to do, to partner with hospitals and partner with primary care providers and others to really make a big difference, because you're going to co-design that system of care for patients over the course of time. That's also really hard to do. It takes time and energy and resources to partner, to meet with people, to go co-design processes, to build the will to work together, those kinds of things. So even though it is very high yield and very important to do, given any situation the situation that you may be in right now, it may be hard to be the first thing that you do. So I encourage you to say that's something that is a goal of ours over time, because that's what it really is going to make a big difference. But you also might say, you know, we want to work on our pain points. We want to work on the waste, maybe, you know, how do we waste time in our agency? How can we be more effective and efficient at the same time? How can we make sure that we're using our resources to the best effect possible? So you may look internally and say, well, we want to know what are the pain points, what drives people crazy, what wastes the most of their time, and that might be a place to start. We're going to improve, you know, internal communication. We're going to improve internal skill on X, Y, and Z, because that seems to be taking a lot of people's time. So you might look internally and set some goals that will be big wins, that will help free up people's time, build their skill and confidence as you move to the bigger pieces. So 2 ways to go about it. Either way that you want to go about it, doing some kind of a diagnostic review like you see on the screen can give you a lot of information on the state of your systems that then you can pick and choose. And then the last thing I'll say is make sure it's important. Make sure it's going to matter, and when you improve it, that your staff and your patients will see some kind of a win out of it. So hopefully some guiding principles.
All right, our next question comes from one of our participants who says, we have a challenge with our audit tool in identifying where we need to improve and focusing on a change in clinical practice. Do you have any medication audit tools?
That is a great question, and I would like to write that down, and the planning group for these calls, I'd like us to work on that together and bring some forward. I don't have any off the top of my head.
Great. Well, we will archive that person's contact information and get back with them individually after we've had a chance to regroup. Our next question is somewhat similar to the first one, where folks were asking how to get started, but this one's about sustainability. This person says, our problem is keeping things going once we stop working on them. For example, we made great progress when we made improvement in medications, but things went downhill as soon as we stopped working on it. Do you have any advice that you could offer us to keep things going once we get them started?
Yes. So one is long-term leadership commitment, that the improvement work you're going to do is going to sustain. And so what that looks like is using that sequence for improvement, so doing really good testing first to understand if we do these things, if we do medication management these ways, we know we get better outcomes. And then doing everything that you can to hardwire those as the way your organization does business. And that takes long-term commitment. I would say in my experience, to really hardwire changes so that they sustain, it's probably some leadership focus and attention for a year or more to make sure that they sustain. And that might be looking at data on a regular basis, understanding when things start to fail and then noticing it, and going back in and improving it, and again, hardwiring those changes into the system. It can't be well, you can approach improvement as the project of the month or project of the year, but if you approach it that way, as opposed to we need to learn how to fundamentally change how we do our work, it won't sustain.
Corey, this is Kate.
Yes.
May I also add to your comment?
Please.
This is Kate Bones, and I also just want to add that I think there's some process changes that do require some kind of long-term monitoring. So after you've implemented your change, if you have continue to watch that outcome measure, the measures that you're tracking that relate to that, and then if you start to see a shift, you can kind of jump on that at the moment it starts moving and kind of get things back in line. And so that long-term monitoring can be important for some things like medications. And I'm also thinking using teach-back, which I'm not sure is a term familiar to everyone, but that's something that we've found teaching patients and having staff and clinicians better teach patients in a way that they can understand is something that really requires monitoring over time.
Thank you, Kate. The other thing I would say is that, and we'll talk more in the next call, but part of what you're learning in your testing is not only what steps to change and how you might do any particular task, but you're also learning what skills and knowledge are needed that might be different from what you have now. You might learn that you want to change your hiring and recruiting practices for different kinds of attitudes, people that are team players, for an example, as opposed to lone wolves. So you'll learn about that kind of thing, and you'll learn in your testing what kind of policies and procedures need to happen. And then as you implement, you learn more about the infrastructure that's needed to sustain the change. And then, as Kate really nicely pointed out, that long-term monitoring of particular things. So you can see it's a process, and that's part of why any improvement work should be important, as opposed to having 10 projects that are all kind of important. It really would be better to have 1 or 2 projects that's really important that you're really going to work on.
Okay, we have one more question for this break, and then we'll get back to the presentation. This question says, one of our biggest issues for us at a home health agency is working with physicians to get them to sign off a face-to-face document. How do you suggest we improve this bottleneck, especially when a competing hospital makes it easier for the physicians to sign the face-to-face? Or what kind of analysis do we need to work on to get a solution to this?
Well, that's a very big question, and I don't have a very detailed answer. What I can say, and so maybe that's one we can put on the parking lot and work on over this series of calls, what I can say is that building partnerships with the hospital and the physicians that you need to work on the process, and then together figuring out ways to co-design the process to make it easier for all parties, to have a focus on what's best for the patient, and then to test changes, how to get it done, will most likely lead to an answer that's going to be sustainable. But Shannon, if we could, I'm going to put that on the parking lot as well. I know that that's a big issue. It's a big design process kind of issue that we can think about.
Sounds good. Well, Corey, let's get back to the presentation. We'll break again for questions here in a few more moments. If anyone has any additional questions, please send them to hhqi@wvmi.org.
All right. All right, so I'm going to stop and ask Bethany a question. I saw the note that you want it full screen. I can't figure out how to move the slides when it's in full screen.
Just double click your mouse a couple times on it. You should be okay. Well,
all right, that's not working. So,
okay.
All right. Well, I will learn to do that on the next call, if that's okay with folks. Because I want to get to aim statements. So writing this aim statement, so you've picked something that you want to improve. Let's just say you want to reduce acute care hospitalizations. Writing an aim statement that has particular elements is really incredibly helpful at setting up your work and in guiding your work over time. So project aim, it's not just a vague desire to do better, but it's really a commitment to achieve a measured improvement. So in a specific system, so my home health care agency with a definite timeline, by the end of 2013 or spring of 2014, and it has numeric goals. So this is what IHI used in our campaigns to reduce unintended deaths in hospitals. This is what we use to get people to write a specific aim. That hope is not a plan. I hope we can do better. We want to do better at some. We want to have some fewer acute care hospitalizations, and we want to do it soon. So soon is not a time. So it's really just to reinforce that writing a specific aim statement is really important. So here's a checklist for great aim statements, and just as a heads up, the homework that we're going to ask you to do for this series of calls is to go and write an aim statement and post it on the website, on the HHQI website. So here's a checklist for great aim statements. It should be important and inspiring yet specific. It should be stated clearly. It should include numeric goals that require fundamental change to the system. You want to set stretch goals, but goals that are achievable. I mean, people could say we want to reduce our acute care hospitalizations to 0, but that's not achievable, and it may not even be the best for patients because obviously there's times that they belong in the hospital. So setting stretch but achievable goals is important. Once you start your work and as you write your aim statement, sometimes there's a desire to kind of throw everything in there. And so you want to really think about what it is you want to improve, not throw everything in there, but be clear and specific and avoid aim drift. And then once you actually start your work, as I said earlier, it's easy to get distracted. There's so many different competing priorities. It's important to avoid aim drift. On the other hand, once you get started, you might want to refocus your aim statement. You might start off with an aim statement that says, I want to reduce acute care hospitalizations by 15%, and that might be the aim statement you start out with. You might start working and say, well, that's not very patient-centered. Maybe 3 months down the road or 6 months down the road, you might say, we want to change our aim statement. We want to say, we want to provide the best home health care quality, the best home health care possible to our patients so that they stay safe at home, that they stay in the right setting, and that they're happy where they are. That might be an inspiring aim statement, and we want to decrease acute care hospitalizations. So that wasn't a very great example, but hopefully enough of an example to say that down the road you might refocus your aim statement. Here is an example of an aim statement that has pretty much most of the criteria that I talked about. So the best home health care agency will improve transitions between the hospital and their agency. So they're very specific. They're going to improve transitions between the hospital and their agency. How are they going to do it? By improving the handover and focusing on medication management during the first week of service. So then they're saying the kinds of things they're going to focus on. And then this gets to the time frame, so that within the next 12 months, we will reduce ED visits by 50%, acute care hospitalizations within 30 days of discharge by 20%, and our OASIS data will show improvement in medication management and medication stabilization by 15% or more. So they say what they're going to focus on, the things they think are important in order to achieve it, and then they have very specific measures that they believe will guide them towards their aim and how much they're going to improve by and within the time frame. So an example of a good aim statement. Here's just those measures put out in a slide that you can see. The outcome measures are reduced ED visits, and reduced acute care hospitalizations, and the process measures are around the improved OASIS medication management and OASIS stabilization data. And I think it'll be on 2 calls. From the third call, we'll talk more about what are outcome and what are process measures and how do you use them. But an example of the measures. And then what changes can they make relate to the BPIPs from the national campaign on handovers, medication management, and it would be my guess that they would also use the BPIP on patient engagement, that they can't achieve their goals without engaging patients in different ways. So an example of an aim statement and kind of walk it through. This slide is really just a summary to say what we've talked about today is the model for improvement. So looking at what are we trying to accomplish in writing that aim statement. How will we know that it changes an improvement? That gets to the measures. And then what changes? What changes can we make to our system that's going to matter? And that leads you directly to the resources that the campaign is providing you. And then on our next call, we'll talk more about PDSAs and iterative learning. All right, I'm just going to go here real quick and then we'll stop for questions. So here's our recommended homework. With your team, write an aim statement for your area, for an area that your agency wants to improve. And if you're not sure what you want to improve, just pick one for the purposes of this homework and write an aim statement. They're actually harder to do than it seems like. So write an aim statement, include all the key elements, and refer to the AIM checklist that we can send out after this call, and then post it to the HHQI website. And then reflect with yourself and your team, how was this? What did you learn in putting this together? So I think with that, Shannon, we have time for just a couple more questions.
All right. Let's start first with a few comments that I wanted to share that have come into us at hhqi@wvmi.org. First of all, this comment says, thank you. I had heard about IHI, but thought that your focus was more on hospitals. Glad to know that you are working with all provider settings. Another comment we received, great ideas on ways to identify how to improve, such as patient interviews. This all takes time, but it is so important, and this participant really likes the idea of 5 patients. That is reasonable. Great information. Thank you so much, Corey. Another comment says, I love the PDSA process. We will start using it today. So
awesome.
one more comment to share. So glad that IHI and HHQI have come together to bring this information to us. Thank you all so much. So those are a couple of the sample comments that we've received. Please continue to keep those coming to hhqi@wvmi.org. Just a couple of quick questions before we wrap up today's session. This one asks, Corey, what types of accountability do you suggest adding to any type of change?
Great question. I think you get that answer through your testing. So if you add accountability before you've changed the process so it's reasonable to ask it of someone. So if I'm a nurse and you say, you know, we're going to make you accountable for these new things because we know they're important. But yet on my home visits, despite my best efforts and best intentions, I have to spend all my time trying to call the doctor and get the information I need or get this paper signed or doing all those things, and I don't have time to do those things. You've made me accountable, but you haven't made it possible for me to do it without heroic measures. And we all know that people in home health care, all the staff, excuse me, are quite good at heroic measures and being incredibly resourceful. What we want to do in improvement science is design the steps in the process so that doing the right thing is the easiest thing to do. Once you've designed that, then putting in accountability processes for competencies and knowledge and doing the right thing, then you're on much better ground to then hold that accountability through competency processes, through audits, those kinds of things.
Next question says, can you tell me more about the upcoming webinars in the Pave Your Path series? Are they more about the model for improvement?
Yes, so we will dive more deeply into PDSAs and doing really good testing. As you can hear from what I've said today, so much depends on really robust testing, and you're learning from it about how to change your system and then how to implement it so that it has a much higher chance of sustaining. So the second call will focus on really good PDSAs and learning and setting up that learning system. The third call, I believe, focuses on measures and the use of data for improvement. And the fourth call, I believe it's putting it all together. I should know that off the top of my head, but as Shannon wraps up, I will find out the focus of the fourth call and put it in the chat.
Okay, well that's all the time we have for live Q&As now. Corey, any closing remarks before we close out today's webinar session?
Yeah, so our next call, as I said, will focus on plan, do, study, act cycles, and then we'll talk about a learning system. So how do you put that iterative learning together to build the knowledge to know how to change your system? I think that's it, Shannon.
Okay, thank you so much for joining us today, Corey, and being our keynote presenter on this first installment of the Pave Your Path webinar series. We'd like to remind everyone that the homework assignment that Corey previously mentioned can be posted to the discussion forums at www.homehealthquality.org. If you need assistance locating that, please email us anytime at hhqi@wvmi.org. We'd also like to remind everyone who may have had a chance to complete the Readiness Assessment that the link was sent to all of you via email. You also see it on your screen right now, and it's also included in the HHQI discussion forum so that you can make sure that you are ready to start the quality improvement process by answering these simple questions for the Readiness Assessment. As Corey mentioned, we have 3 more installments coming up with the Pave Your Path series. We hope everyone is able to join us for those. Our next will be March 19th at noon Eastern using the model for improvement. Then on April 16th at noon, we'll be talking about learning toward improvement. Then we wrap up the 4-part free series on May 21st at noon Eastern also with improvement science and helpful techniques. So once again, thank you all so much for joining us for Pave Your Path #1, a joint presentation by the Home Health Quality Improvement National Campaign and the Institute for Healthcare Improvement. Once you log off today's webinar, there will be a short series of questions through SurveyMonkey that will ask for your feedback about today's webinar session. Since this is a series, please try your best to answer these questions so that we can continue to improve our offerings for you in the subsequent series. Thank you all so much for joining us today, and we look forward to seeing you in 4 weeks. Have a great day.
Thanks, everyone.